answered A. Why did you not? Oh, okay, so we had some answering A, okay. Who answered B? Who answered B? Commit to your answer. Don't, this isn't about right or wrong. This is helping me help you. Who picked C? And who picked D? Now let's go through these. This question is asking you what is right about vasculitis. So what is vasculitis?
Inflammation of the vessels.
Inflammation of the vessels. So, where does inflammation come from?
Immune response.
It's an immune response. So, that is how you're going to have to break these down. You're going to have to look, these are easier, but this is the process. What's it asking me? It's looking for something right. It wants to know if I know what vasculitis is, and more importantly, how the patient or the body responds to vasculitis. So why would an atherosclerotic plaque be right? What is that? What is plaque? It's fatty buildup, platelet buildup on the vessel wall, and it isn't, with vasculitis, the entire vessel is inflamed. So what? Why do we care? Why does that bother anything? What is a vessel? What is carried in a vessel?
Blood.
Blood. What's in the blood?
Oxygen.
The most important nutrient our body needs is oxygen. Without oxygen, every tissue will die without it. So if our vessel is inflamed, what does that do to the vessel? It makes it smaller. So less blood can get through it. So we're caring for a patient that has vasculitis. What labs would we correlate with this?
ESR.
An ESR, what is an ESR?
It's your inflammatory rate.
Do what?
If it's elevated, it's inflamed. It's
What is it?
erythrocyte sedimentation rate.
Okay, and it's an elevated sed rate. Okay, so that is just something that we look at. Is that with chronic or acute inflammation?
Acute.
Is it chronic or acute? Does anybody want to?
I'd say both.
It's acute.
Yes.
What else? What other markers do we look at?
Like
CRP. Why do we look at a CRP? What is a CRP? C-reactive protein. It's just inflammation markers. We draw the blood and we look for a sed rate. An ESR is also what it's called, an ESR, sed rate, all the same thing, or CRP. If they're elevated, we know that there's inflammation somewhere in that body. So then we have to do our assessment skills. There's usually what with inflammation? What? Swelling and pain. So if somebody comes in and they're like, oh, my ear hurts so bad, and then they do an elevated sed rate test, which is just a blood test, or a CRP, they know that there's inflammation somewhere. If it's a sed rate, we know it's been going on for a while, so it's chronic inflammation. If it is a CRP, we know it's probably a new infection. So as a nurse, you need to know that inflammation, sed rates and the CRPs go with inflammation. How do we treat inflammation? What is a drug of choice?
Ibuprofen.
Ibuprofen. Ibuprofen's a good one. What do I? Steroids. When we give steroids, what does that do to our immune system? Suppresses it. So we have to be very careful that we're not giving it to somebody that might be fighting an infection and needs their immune system. So it is a very wobbly slope. Okay, so we look at labs. Now, if you are giving, I heard that we were going to give Motrin, ibuprofen. Before you give that, a prudent nurse checks what blood level. You must know this.
You want to test kidney?
Kidney. And how do we do that? Through what?
BUN and creatinine.
BUN is more related to hydration status. Your BUN is going to bump if somebody's dehydrated or absorbing blood. If their BUN is up and the creatinine is not, that does not mean they have renal problems. That is a hydration problem. That is an absorption of something. If our creatinine is high, we would not give the ibuprofen, the NSAID, because why?
It's gonna build up too much in the system.
It'll build up, but why?
It's not
It
filtered.
can't filter because the filter of the kidneys is clogged. Okay, good. Now, so we talked about the atherosclerotic plaque. High blood pressure is damaging the delicate lining of the arteries. Well, why isn't that right?
It's not.
Do what?
It doesn't mention the application after.
It doesn't match. That's a true statement, right? It messes with the vessels, but it has nothing to do with vasculitis. Now, the blood pressure may be high because the vessels are clamped down with inflammation, but that is not the right answer there. That is not the pathophys it's looking for. Your platelets are extra sticky, so they form lots of clots in the blood vessels. Has nothing to do with vasculitis. This question was seeing if you understood vasculitis. That's the bottom line of it. What is right with vasculitis? Let's look at number 2.
So that would be like one of the lower level questions.
You would have to know that. I mean, yeah, it would be. But we're learning from these. We're putting it all together. Okay? A 68-year-old woman with a history of polymyalgia rheumatica comes to the clinic with blurry vision and headache for the past month. A temporal artery biopsy reveals infiltration of giant multinuclear inflammatory cells. Based on these clinical findings, the patient is at risk for. So the first thing you ask yourself is, what is this question asking me? What is important or clue in this question?
Her symptoms, so where do you
She has the symptoms are good, are a very good sign. More important though, where was the biopsy? The where? Temporal. So what does that tell you? And it may not tell you anything yet, but it will after tonight. And that's why we're coming to these. So we have this polymyalgia rheumatica. What in the world is that? Does anybody even know? It's basically when this is another inflammation question. It's inflammation of the vessels right here on the scalp by the temporal. I do this really bad, guys. I do not talk well, and I talk backwards, and my brain works faster than I can get stuff out, and it goes all over the place. So just bear with me. Okay, so it's right here in your temple area. You need to understand anatomy now, and you need to answer that question. I'll give you about 15 more seconds, and I want you to commit to an answer. Have we all picked one? How many of you picked A? Don't be afraid. How many of you picked B? How many of you picked C? And how many of you picked D? Okay, now let's go through these. We have a person with a temporal artery biopsy. We know that anything with your temples, with a temporal arteritis, the symptoms of that and temporal arteritis is inflammation of the temporal arteries right around there. And that's what this temporal artery biopsy reveals, infiltration of, that is a symptoms of this, and we know it's a temporal artery. Vision loss, fatigue, and headache. This question, whoever wrote this question was saying if you knew what is expected when you have a temporal biopsy for temporal arteritis. You had to look at the symptoms there, and you had to look at where the biopsy was, and you had to critically think to see. Of course they put seizures, cerebral aneurysm, and what was the other one? Embolic stroke, because it's your brain. That was a trick, that was misleading you, that was wanting you to pick those because it's your brain. Seizures, what causes a seizure? Brain swelling, if you're too hot, too cold, epilepsy. But a biopsy there shouldn't. Biopsy shouldn't, unless it's a tumor, and the tumor's causing it, not the biopsy. Okay, so what vision loss is the right answer because that's a symptom. Cerebral aneurysm, what is that? What is a cerebral aneurysm?
Weakness in arteries.
A cerebral aneurysm is when the vessel is weak and it bulks out. A biopsy wouldn't cause that. Temporal would not cause that. An embolic stroke, what's an embolic stroke? It's a blood clot, basically. We have lots of, a stroke means there's oxygen not getting there. It can be a bleed, or an embolic stroke, or a clot, whatever you want to call it. It just means there's a dead end through that vessel and blood can't get any further. The right answer on this is B. This question was seeing if you understood the landmarks of the body and what would happen if you had temporal arteritis. I beg you, everything I say tonight, you try to find error in what I say. You go and you look this up. That is a learning process. If you think, man, she's full of it, go look it up. Because you will find it's correct. And you will find it's fascinating. The body is amazing. It's amazing. All right, number 3. The physical examination of a 58-year-old woman reveals the following. Elevated erythrocytes, ESR, temporal artery tenderness, and blurry vision. A biopsy of the temporal artery confirms a diagnosis of temporal arteritis. While caring for this patient, the healthcare provider will anticipate an order to administer what? Here you go. Here's some. I need you to sign. Okay. So again, what is this question asking me? What's it saying if I know? What's it looking for?
How to treat arteritis.
What?
How to treat it.
How to treat.
Inflammation.
This is saying if you know what treats inflammation. That's basically what it's asking you. Okay, are we ready? How many of you picked A? Good. How many of you picked B? How many of you picked C? And what about D? Now let's go through this. Why are we going to give steroids? That's what that is. Why
Because
are we
it
gonna give
depresses
steroids?
the immune system.
And so if we dampen the immune system, what is going to be the result of that? Less inflammation. Why would we not give anticoagulants?
It's irrelevant.
It's not a.
It's not a blood clot. One's anticoagulants do. Thins blood, keeps it from coagulating. Antibiotics. We give antibiotics for a lot of things. This sounds good to me. Why not?
Not a bacteria.
It's not a bacteria. That's right. Ferrous sulfate. Okay, so we don't know what that is. What is that?
Iron.
Iron. Ferrous sulfate is iron. Our pregnant ladies like the ferrous sulfate. So it was just seeing if you knew what these meds were and how to treat inflammation. Okay. A 44-year-old male with a history of heavy smoking comes to the clinic complaining of paresthesias and pain in the hands and fingers. The patient states, my hands hurt even when I'm not using them. Radial pulses are 111 and the fingers are cool to the touch. A diagnosis of Berger's disease is made. The plan of care for this patient will include. What is this question asking you?
How do you treat
How do you treat Berger's disease? And you can say that thromboangiitis, whatever, whatever. It's just there to throw you off. This is asking, how do you treat Berger's disease? Okay, we get another one. I gotta make more copies. I'm glad to have you. And there's a sign-in sheet back. For those of you that came in late, you will need to see me afterwards to come and get a form for hours. Okay, so we are on number 4. We decided this question was asking us basically what is Berger's disease. Do what?
Is it brain mass?
No. So, how many of you are done answering it? You're done? Okay. How many of you picked A? How many of you picked B? How many of you picked C? And how many of you picked D? How many of you knew what Berger's disease was? What is it?
Oh. I only know the answer because it was on our last exam and I missed it and I looked it up after class. But the only way to stop it is to stop smoking,
To
right?
stop
Yeah.
what's causing it.
Yeah.
Berger's disease is usually caused by smoking. Now you're going to get to hear my spiel. Nicotine is a very, very ugly drug. Nicotine causes what in the body? Why does it cause so much trouble? I mean, yes, we know what it does to the lungs, but what's it do to our vascular system?
Constriction.
What's it do?
Inflammation.
Constricts.
Well, that's great. It gives us a high, makes our heart beat a little bit faster, makes us feel more alive. That's great when you're 20s, 30s. By the time you start getting 40, you start seeing effects. By the time you're 50, all those little blood vessels that you've clamped down, maybe not your aorta because it's pretty big, but your nose, your toes, your penis if you're a male, are dying. And they have not gotten blood. They have constricted so long that blood flow has been restricted to these areas. Many men, by the time they're 50, will be impotent from smoking. Because impotent, they will not be able to get it up. They can't quit smoking because they're addicted. Smoking and nicotine. Chewing is just as bad. By the time they're 60, the little vessels, if they don't get cancer, they'll have peripheral vascular disease because their vessels are so clamped. It is really sad. It is very, very sad that a drug will cause this. We had a lady, and a lot of times it runs with diabetes because, they haven't ate right, whatever. But I am telling you that many people will come in and will say, you have to quit smoking. You cannot smoke. If we cut your leg off, we're going to have to cut your leg off. If you don't quit smoking, cut my leg off, I'm going to smoke. But if we cut your leg off, your stomach's not going to heal. We're just going to have to keep cutting it off. And they'll say, give me a cigarette. True story. We have a nurse, that's an amputee, and she smokes like a chimney. And she, oddly enough, works in rehab. And she gets her on a prosthetic pretty good. She still goes out and takes her smoke break twice a night. She called me very upset because her patient outran her. Who's on rehab. What do you say? I mean, she's like, I have a prosthetic. You can't be putting these people. He's in rehab. I mean, it's like, okay, quit smoking. She can't quit. So my point is, nicotine is a horrible, horrible beast. When you're young, it doesn't matter, but as you get older, it really takes its toll. Your organs aren't young anymore. They cannot put up with it. And then they just keep smoking more and more and more, and then they get hateful and hateful. That's my theory. I don't think that'll be on the index. Okay. Okay, so we're gonna quit smoking because we know that burgers, you have to treat what's causing the problem. And that is what it is, and it's smoking cessation. Okay, let's go to number 5. The patient has a diagnosis of polyarthritis nodosa, which has stenosis of the renal arteries. The healthcare provider, which is you, will expect which of the following problems to develop because of this stenosis? What's this question asking you?
Of the renal artery.
So take about 15 seconds and answer this. I'll give you 30 because it's probably more. Okay, how many of you chose A? How many of you chose B? How many of you chose C? And how many of you chose D? This question is seeing if you understand how the body stays in a homeostasis. Meaning, if there is stenosis to the renal arteries, what happens? What does that mean?
It's blocked.
It's blocked, it's closed from the renal arteries, from the the vessels leaving the kidneys. Okay. What happens in the blood from the that's leaving the kidneys? What's carried in that?
Oxygen.
A lot of hormones that affect our blood pressure. If that is blocked, we are going to have issues with blood pressure. We will have high blood pressure. How many of you have cared for a renal patient that's on blood pressure meds? That is because our kidneys play a huge role in the balance of our blood pressure. There's baroreceptors, and we're going to talk about that more later in this. What is glycosuria?
Sugar.
Sugar in the urine. Where are we going to see that? Diabetes. Diabetes. We're going to talk about something fun in that in a second too. Polyuria. What's that?
Peeing a lot.
Peeing a lot. Peeing a lot. Nocturia. Hypertension. So the right answer is D. This person writing this question thought that they could get you, and I'm not writing these, by the way. Some of these this one's not mine. This person was saying they knew that you knew that the kidneys probably created pee. So they were going to see if they could confuse you. But the fact of the matter is, blood getting to the kidneys could cause what? If we had stenosis getting blood to the kidneys, what would happen to our urinary output?
Decrease.
It would drop. It would, if you didn't get enough perfusion to your kidneys, you're not going to have pee coming out, period. Yes, Tina?
So let's say I was looking at this and I had no clue. Could I just use like what does it fit? Like all of them deal with urine? Could I just, would that work in most cases?
You know, there is strategies. This is a lower level question, and it's not, you either know it or you don't.
Yeah.
It really, I mean, you could look at it and say, oh gosh, and there's lots of thoughts that, oh, there's 3 urines, so it's got to be one of them, and they're trying to trick me, or it's got to be the, odd man out. It's best to just know it. We will learn strategies after we've learned content. That's a great question. Okay, let's look at number 6. A patient with a diagnosis of Church-Strauss syndrome exhibits allergic and asthma-like symptoms. Based on these symptoms, the healthcare provider would expect a complete blood count to reflect which of the following. What's it asking you? What's it saying if you know?
Which? Yeah.
It's looking to see if you know what allergic and asthma looks like on a blood test. So go answer. you got 10 more seconds. Okay. How many chose A? How many chose B? How many chose C? How many chose D? The correct answer is A. And now we're going to have some fun fact times. Okay. Your immune system has kind of been the whole topic of this test, inflammation immune system. All the time in your body, in your blood, you have what is floating around as little neutrophils. They're so happy. They live about 5 to 90 hours. All they live for is to protect you. That's it. So they basically, if they're at this stage, they're mature. They're just floating around waiting. If something happens, we'll say this is infection. I don't know. These guys that are here, once they leave the blood system and they go and attack this, which we call it phagocytic, they die, but more produced from the bone marrow. Now, these are granulocytes. Do you know why they're called granulocytes? Do what?
They're like little grains inside.
I call it magic juice. In each cell of the granulite, which is your neutrophils, your eosinophils, your basophils, they have like magical Batman power. So when they go here and this little granulocyte, whatever, when they hit this, it like spits it out of them and it dissolves it. So the bacteria is killed. Now, many times when you are in the hospital, you'll hear this fancy thing called shift to the left. Who even knows what a shift to the left is?
I read it and then I forgot.
Like you're saying in your bands.
Does it mean all of your levels are shifted lower than what they're supposed to be, like?
No.
Down?
So,
You've got like immature.
you're immature because remember I said these all had a nucleus. So these were mature. When this thing happens, the bone marrow spits out little bitty baby ends or neutrophils, but they're bands and segs. Whenever there's an acute infection, whenever the body is at war with whatever, these little bitty baby ends called bands and segs are released from the bone marrow to go fight this. They never get a brain, they never mature, their whole thing is to go kill this so you'll be healthy. Somebody years ago, whenever the doctor would order a WBC, a white blood count, we didn't have the technology we have now. So somebody in the lab, the micro lab, would sit, look underneath the microscope, and they had a section with segs and bands that were on the left, and all the others on the right. So as he looked underneath the microscope, every time he saw a seg or a band, he'd make a little mark on the left-hand column. He would call up and say, hey, you got to shift to the left, meaning there was more marks on the left than on the right. They were nucleated. Nucleated cells would have a brain, these didn't. So there was unnucleated bands or segs, babies fighting in the blood. A shift to the left is just a way that they used to say how their documentation was. That's all that means. Infection. It's just a shift to the left is saying there's more bands, more segs, it's a shift to the left. Now, how many people have taken care of a diabetic? Quite a bit of you. Do you know what diabetes means? Do you know what the word diabetes comes from in Roman or whatever? Sweet pea. Truthfully, sweet pea. It is, look it up, sweet pea. How do they know that? They used to drink it. They would smell it and drink it to see if people had sugar in their pee. That was how they diagnosed diabetes. This was back before we became civilized, I guess. So, diabetes is a funny thing because all of these neutrophils and all of these things that are built to protect you, if you put them in a petri dish and you put half of it with bacteria and you put carbs and sugars here, and then you put your immune system, your white blood cells, your neutrophils. Guess where they go?
Bacteria.
They go eat the carbs and the sugar, and the bacteria grows and just multiplies. Because neutrophils, like most of us, appreciate carbs and sugar. So what does that tell you? When you have a diabetic and you say to them, your blood sugar is 250, your blood sugar is 350, and they have a sore, a gaping wound on their foot, their butt, the back of their head, wherever, where's our white blood cells? They're eating all the sugar, and the bacteria, and that wound is getting bigger and bigger and bigger. That's why we want to keep their blood sugars down. I think that's very interesting. That has always amazed me. And people, again, like the smoking, they would rather have their cupcake than their lamb. So, I'm probably just as bad on that. Okay, so we know the eosinophils are going to be for allergies and asthma. They will be elevated. That's what the EOs do. Allergy, asthma. Your thrombocytopenia, what does that even mean? Platelets what?
Low.
Low, less than 150. What is granulocytosis? Increase. Too many granulocytes, which would be your neutrophils, your basophils, your eosinophils. And then your neutrophilia is when you have white blood cells. But on this one, it was looking for allergic and asthma-like symptoms, and eosinophils is what you need to be able to pick out there. All right, number 7. A 4-year-old child presents to the emergency department with a fever of 104 degrees. The parents state the fever started almost a week ago. Examination reveals conjunctivitis, cervical lymph node adenopathy, and peeling rash on the hands and feet. Which additional assessment will confirm a diagnosis of Kawasaki disease? So what's it asking you? Do you know the symptoms of Kawasaki disease? That is what it's asking. Go find the last symptom of Kawasaki disease in that answer. Okay, who picked A? Who picked B? Who picked C? And who picked D? That is right. Kawasaki was on mine in CLEX 105 years ago, and I did not know it. So I always want to make sure everybody knows that. Let's go on to number 8. A 9-month-old child is transferred to the pediatric unit from the emergency department. The patient is febrile and fussy. He has conjunctivitis and bright red lips and tongue, a body rash with peeling skin on the hands and feet. The parents say this started with a fever about a week ago and has progressed. For which priority diagnostic will the healthcare provider prepare? picked B? Who picked C? And who picked D? All right, now let's talk about Kawasaki's disease. What happens in Kawasaki disease? It's inflammation, basically. It's inflammation, that's why you see that big red, the cherry stuff. The problem is, with Kawasaki's disease, about 2% of the kids that get this die from cardiac complications. Because the coronary arteries have inflammation, it leads to not enough blood flow. The kid's heart has bad cardiac output. The main thing you have to remember with Kawasaki's is the child's heart, they get heart disease. Okay? So if they have heart disease, what diagnostic are they going to need every year or two after Kawasaki's until they're grown to make sure that they didn't have functional damage to their heart?
Okay.
An echo. Well, what would a blood culture? Kawasaki's disease is not contagious. It's a vascular inflammation. That's what it is. It causes inflammation in the vessels. It is only harmful when it gets to the heart. 2% of the kids will die. A blood culture, it's not going to grow anything. Why wouldn't we do an EKG or electrocardiogram? They're probably going to be a normal sinus rhythm. They may have some ST changes if the vasculitis got bad enough that the blood flow was there and the heart muscle was dying. But there should be signs like pain before that. And then why not a chest x-ray? It's just going to show the outline of the heart. It might show a big heart, but it would not show the functioning of the heart. So what's the difference in an echo and an EKG?
Echo looks at the walls of the heart and changes.
Echo is going to show us how the valves are working and how the EF is. What is a normal EF in an adult? 55% or higher. And I'm assuming a pediatric is the same because we want to be able to, the cardiac output is how much blood is leaving that left ventricle. So when we do an echo, we are looking to make sure that there is no blood going the wrong way in the valves. And we are making sure that there's a good cardiac output or a left ventricular kick. Okay, let's go to number 9. The healthcare provider is caring for a patient with a diagnosis of Kawasaki's disease. Which of the following medications should the healthcare provider expect to administer to decrease inflammation and thrombosis of Kawasaki's disease? And I needed to write here, after the fever settles.
How did you say that they got this?
Kawasaki, it's inflammation. It's not contagious. It usually lasts about 5 days. It's throughout the face, everywhere vascular, you're going to see inflammation. High fevers, because inflammation, the body thinks something's wrong. That's the immune system, so we're going to have a fever with it. Okay, who chose A? Who chose B? Who chose C? And who chose D? Okay, now I know why all of you chose D, because of the inflammation and steroids.
It was hard because I thought the little C was kind of what I wanted to do, but I thought if I could do one thing for the patient, I just wanted to reduce inflammation.
We would, okay, and before this question, what did I say was the biggest risk for children to die of? Cardiac. Which one of these meds, if a child is fever-free, would have a cardiac component? as well as an anti-inflammatory at low doses. Aspirin. Yes. So we tell our adult patients, take a baby aspirin. That's for cardiac, that's for, to blunt, to prevent blood clots.
She'll take the pain. Yeah, it makes sense, like the pain.
Now, but I keep saying after the fever settles. Why is that important? It is contradicted to give children aspirin with a fever. Why?
Oh, there's that one, the one disease. There's
Right.
another disease.
Yeah.
I remember that. Yeah.
Kicks their brain and their liver, Rye syndrome.
Right.
So you have to wait until there is no fever. I don't know how it happens, but it happens. So no fever, Rye syndrome. Because of Rye syndrome, you're going to give an aspirin for Kawasaki's after the fever has settled. So it's usually 5 or 7 days if they have a fever. That's going to be after.
Is that only with children that get Reye syndrome?
Yes, adults don't get Rye syndrome, and adults don't get Kawasaki's disease.
Yeah, I remember that.
So then prior to the fever, would you just give a steroid?
You would treat the symptoms, and so how would we treat these symptoms? We got a baby with a fever and pain and inflammation. So what are you going to give? What do you think they're going to give?
Cool. Rain.
We could give ibuprofen, we could give Tylenol, and they may give a few steroids. This would be an acute phase. Afterwards, remember we said for years we have to check the heart because your vessels are going to have long-term effects from that vasculitis in the heart. They're going to have to take that aspirin long-term, and that is why we're giving it. Yes?
This might be kind of a silly question, but this doesn't have to do with immune, like your immune.
Immune system, yes. Anything with vasculitis is immune. It's the body reacting.
So why would you still give like the prednisone while they're still feverish? If it's just gonna continue to lower. the
Well,
immune system?
because it's vasculitis. We aren't fighting anything but ourselves. How many of you, this is a perfect time to tell you about my son. He has TRAPS, TRAPS. It's an autoimmune system disease. Very, very, very rare. Very rare. He, at 15, started getting sick. When puberty hit its max, his body, it created stress on him. And his body saw stress as bacteria or an injury, and it went and attacked it. Problem was, stress of puberty or exercise or a bad grade was systemic. And his body went crazy. We went from him being the roughest, toughest, meanest, and I kid you not, he's the third of 6 kids. He was just crazy, just balls to the wall all the time, to a hurt, injured child. We went through mono. We went through boils on his arms, and I'm talking huge lesions on his arms. Just one illness after another. We didn't know what it was. Literally, he could not. He was a big basketball player. If he went to practice, or much less a game, he was sick. He'd go to bed, he'd rest, he'd get better. It kept getting worse and worse and worse. Now he's probably 17. Now we're fighting it all this time. I had taken him in to urgent care. Actually, my son brought him in and I met him because I was working. And they thought he had Stephen Johnson's disease because he was taking Bractrum. And he had a big rash, so they wanted him to come right on in. He just wasn't himself. So we took him in. They said it wasn't Stephen Johnson, sent him home. It was about 5 o'clock. At 7 p.m. I got off, went home, found my son unresponsive in bed, had blood in his head. It was a bad deal, unresponsive. I held my own child's airway until EMS arrived. Now, there's a lot of important parts of this story. When EMS arrived, I was like, thank you, just help me. Help me. I was exhausted. I was frantic. I was alone. And they came in and they said, what do you take? What do you mean, what do you take? He didn't take anything. Oh, he's an overdose. Now, I know this sounds stupid, but I live in a nice home, gated. I thought that I don't mean to sound bad, but it'd be about that. I didn't think they'd, wrong. They came in with a flashlight and I had my medicines beside my bed. He starts shining them. I'm still holding my kid's airway. I finally got him on the ambulance and they're still sure he's an overdose. Never did an assessment. Wouldn't let me ride with him. I called Dr. Ross in the ER and said, my baby's coming. I need your help. And he met me. And they beat me just because I had to lock the door and I was just, couldn't find anything. My mind wasn't right. Dr. Ross is like, this is your kid? But they called it in as an overdose. Thank you, dudes. My kid's blind in his left eye. My kid had a heart attack. My kid was in renal failure. He had multi-system failure. He had traps. We still couldn't get it diagnosed. I mean, when you opened his eyes, they were blood red both sides. I had a doctor tell me that did he rub his eyes? They couldn't find anything, so they got stupid. They did spinal to everything was negative. It's his immune system was what's doing this. So everything's, there's no high white count. There's no nothing. There's fever. There's organ death. Because we talked about this. Whenever an immune system goes crazy, we have inflammation throughout the body. Your body clamps down so bad that it can't do anything. So I begged Dr. Trotman. I went to, and my boy was still 17. I begged him. I literally got on my knee on 9 West and said, I'm begging you to look at my boy. He's going to die. He's like, oh my God, I don't do Dr. Trotman, please, please. Bring him in. I'm like, well, he's on peds. I want you to go see him. Okay, let's see him. And I'm right on his butt, you know. And he's like, wow, this is, I don't know. They treated him 32 times for strep. Yeah, we don't know what it is. Well, every time they treated him with antibiotics and put him to bed, the body rested, there was no stress, the inflammation went down, he got better. But there was always residual. There was always something left. So this last time, like I said, he's blind. He's got cardiac, his left ventricle, it's bad. So Dr. Trotman, he did everything he could, and he kept watching him. He kept watching him come through. And one day, oddly enough, I was on clinicals, on 9 again, and I had students with me. And he's like, hey, how's your boy? I'm like, he's sick. He's going to die. He's like, why didn't you call me? I said, what's Good's going to do? I've called everybody. I've begged. I've pleaded. It comes, it goes. Every time the kid goes to basketball practice, he's down. He's just like this. Oh my God, it's traps. Come with me. So here I went and all my little students, we set up this computer, and there it was. It was traps. It was an autoimmune disease. All he needed was steroids. Now, it was a huge deal trying to get this kid treated because nobody had treated the pediatric traps before. So Jesse, he was now a senior, and we are playing kickapoo. Glendale plays, who went to Glendale, who went to kickapoo? Anybody in here? Big rivals. Glendale's playing kickapoo. That's all he wanted to do is play ball. So he asked Dr. Trotman, can I play? Oh no, I asked him, can he play? Dr. Trotman's like, yes. And I said, will it kill him? Might. Jesse's like, I'm dying anyway, Mom, let me play. Let me play. So the school made him get these god-awful goggles, you know, because he's only got one good eye now, and he turns blue if he runs very long, but he wants to play. So you go play. Dr. Trotman went and sat right by me. Now you have to understand, my boy's still he fights, kicks, crawls, he's a fighter. He went out there, he was the roughest, toughest for a minute and a half. By 2 minutes, Dr. Trotman's like, hey, your boy's going to get down. I'm like, I know. He's like, you better get him off. Well, I'm not coaching him. Kickapoo. So finally, the ref called timeout, got him out. Dr. Trotman, we took him to the back and he filled him up with steroids. In 45 minutes, my boy was fine. Steroids are amazing. Autoimmune sucks. And it is your whole body. Now he's now 20, he'll be 21 March 1st. And he's my Jesse. You'll hear me talk a lot about my Jesse. Every time he gets off work, he calls me, hey, Mom. I mean, it's just Jesse. He has went through hell, and there's a lot to be learned by that. You do not look at your patient and just assume he's a kid, so he's overdosed. You take care, even if he had overdosed, help me. My kid's, come on, he's gurgling, help me. It was a bad deal. So we have to keep assessing and we have to keep fighting until we find the right keys, the right clues to help people. That's exactly what Dr. Trotman did. We had done everything. We had done every test now. Dr. Trotman finally found it. Jesse still goes and sees Dr. Trotman because there's no family practice doctor that knows how to treat traps. Last time Jesse went to get his, just to see him really, they talk all the time. And Dr. Trotman's probably the richest man I know, and he rides a bike to work, and every time you see him, he'll tell you how to save money. Okay, but he's all the time about saving money. But, so Jesse goes and sees him, and I didn't go to the last time. And it was kind of funny because, I've been there every time. Jesse's grown up now. And he's like, where's your mom? Well, she's not here. He's like, I just want to tell you I've diagnosed 3 traps and they're all dead to you. Traps is nasty. More importantly, people don't know how to treat it because they just want to assume. Well, there's nothing wrong. It's a virus. It's a virus. That's a good one. It's a virus. We can't treat it as a virus. Okay, well, this virus is going to kill him. So don't ever judge people and don't ever quit looking because it's somebody's most precious possession in the world that you've got control of. And Dr. Trotman, if he walked in right now, I would cry. And he'll say, I just have no effect on women. Not really. Not really. It's your brain. So, okay. So autoimmune, it does all the vascular, it constricts, and it is bad. And so steroids takes that inflammation away. Okay, so now where are we at? Oh, this is the next one. It's number 10. A patient who is in cardiogenic shock has a urine output of 20 mils. When further assessing the patient's renal function, what additional findings are anticipated? Select all that apply. What is cardiogenic shock is what you should be asking yourself. What should I expect to see?